Good morning, everybody. Greetings from Triple M Hospital. I'll be taking you through the next case. My name is Dr. Sean Del Rossi. So our second patient is a 50-year-old male with a current weight of about 83 kilos. He's a known patient with a coronary artery disease, suffered an anterior wall myocardial infarction, a known patient with renal failure, diabetes, and hypertension. In April 2015, he underwent a coronary artery bypass surgery using 4 venous grafts, one to the left anterior descending artery, one to the diagonal artery, one to the obtuse marginal artery, and one to the posterior descending artery. And his post-op was complicated with some mild mitral regurgitation. On his 1-month follow-up, he was detected to have significant mitral regurgitation with features of heart failure, and subsequently underwent a mitral valve replacement using a 29mm perimount bioprosthesis plus devagus tricuspid annuloplasty. On examination, he was dyspneic at rest. He had a pulse rate of about 90 per minute, which was regular, a blood pressure of about 120 by 70 millimeters of mercury. He had an elevated JVP. Cardiomegaly was noted. His heart sounds S1 and S2 were normal, with a pansystolic murmur heard at the apex. His ECG showed a sinus rhythm with a ventricular rate of 75 per minute, a QRS duration of about 100 milliseconds with a QRS axis of about 120. On his chest X-ray, showed situs solitus levocardiothoracic ratio of about 60%, with features of pulmonary venous hypertension that was noted. On transesophageal echo, we can see a dilated LV, a well-functioning mitral valve prosthesis with a lateral paravalvular leak. On color flow Doppler through the same, we can see a large paravalvular leak on the lateral side, immediately posterior to the LA appendage, which was measuring about 12 millimeters. Mild valvular mitral regurgitation was seen with severe paravalvular regurgitation. Moderate tricuspid regurgitation was noted with a peak gradient of 77 millimeters of mercury with an RVSVP calculated of about 87 millimeters of mercury. On a 3D reconstructed image shows the large paravalvular leak, which is measuring 12 millimeters posterior to the left atrial appendage. Just today morning, calculated hemodynamics that were noted, a PA pressure of systolic of 75, diastolic of 28 with a mean of 43, aortic systolic pressure of 105 with a diastolic of 62 with a mean of 78 millimeters of mercury, and an RA mean pressure of 13. The rest of the hemodynamics will continue as we do the live transmission. The plan for today is a device closure of the mitral paravalvular leak. Thank you.
Hello.
Okay, Shiva, we see you.
Yeah. So you heard the you heard the story. Now what we are planning to do is use echo navigation. Show the screen live. Show the screen live. Yeah. You see the right side of the screen is the echo navigation screen, and left side is the regular fluoroscopy. And you can also appreciate at the bottom of our screen a live echocardiography. History. Just show the endoatrial septum. So right now, I am planning to puncture the atrial septum on echo navigation with our previous marker. I can show you the marker where it is. You can appreciate here that there is an intraatrial septal marker, IAS, you can see. So that was the marker that we had made based on our fluoroscopic initial assessments. So, Srija, are you able to see the needle? Yeah, I'm able to see the indentation on the screen now. Show it, Srija. Shaq, are you able to see the pictures?
Can you? Yes, we do. We see the echo is very small.
Can you enlarge the echo pictures instead of 2 fluoro screens?
Yeah, echo can be made larger. Make the echo there.
Yeah.
Srija, show me the intraatrial septum. I'm not seeing anything. Go on, explain. Show only the echo. Make the echo big. So show me the position of indentation. That is indentation. I want to see the indentation. Keep pushing and pulling the probe in and out.
On the TOE, do you see an indentation?
I'm not so far seeing Shaq, so I'm just waiting for.
Yeah.
No, I'm not seeing an indentation so far.
That's it.
There at the bottom left. Doesn't look as if they can make the echo pictures big for us.
Echo bigger. Echo, make it very big. Make the echo. Yeah, fine.
Yeah. Okay.
Srija, I'm not seeing the needle tip at all.
It's in that corner.
Okay, let me again come back. Get me the wire. So I'm going back to the superior vena cava. And flushing the catheter needle.
Can you tell us where you like your septal puncture to be, depending on the perivalvular leak? Do you have a preference?
Yeah, basically, I in this patient, since it is lateral, I want to just go in the usual area of the fossa ovalis. That also should be fine. If it is much more medial, then I will try to get in, show the superior vena cava on the X-plane. On the yeah, fine. Okay, I think I have crossed.
Yep, that's it.
So now we have the left atrial pressure. Get me the pigtail. Show the LA pressure now. We can appreciate a markedly elevated LA pressure. Show the hemodynamics big. The LA pressures are having a V waves of 75, 74 with a LA mean pressure is like 32. So it's a severely elevated LA pressure. Now get me I'll make a contrast angio. Give me a small amount of contrast. I'll just check that the patient is having severe renal failure. So I'm intending to avoid some contrast. However, I'm just checking the position of my catheter. Now I want a stiff wire.
So, Shiva, you carry on. There are a couple of questions. So don't stop working. Joe first.
Yeah.
Yeah, we do actually tailor the transseptal approach these days, and certainly for the lateral ones, we tend to go a little bit high and posterior, very similar to what we do for left atrial appendage and mitral clip. If they are medial, we tend to do a low puncture, and these days, with the experience of PVI, we tend to have a lot of experience with
normal catheter
puncturing the septum low down. So we do tailor it according to where the paravalvular leak is.
Shustov, or the microphone on there?
Yeah, basically here it was, if you see the,
no question.
Can you, okay, I'll show you one picture. See, this is the place of our intraatrial septal puncture, and that is the location of the paravalvular leak. So we have got a lot of space between the intraatrial septum and the paravalvular leak. So this is the red mark is the paravalvular leak. So we hope that the distance should be reasonable enough. So right now I have got a right coronary catheter across the stiff wire. I'm planning to use a full star flexible.
Shiva.
Yeah, Shaq.
Shiva, you carry on working. I'm just going to ask Alison, because this is quite a large leak and it looked a bit circular. Very briefly, Alison, what would you be doing?
Stiff wire.
We typically put an in-away wire in now, dilate the septum, and then use the dexterity sheath, which is two-way steerability, and then our monorail kind of multi-purpose
And device?
steer through. I would consider placing an AV rail, exteriorizing it through the aorta, and then you have complete control. And we would use a series of devices, probably for something that's completely round and a bioprosthetic valve. You have quite a bit of room, but this would require a large plug. So we might try two AVPs.
Okay.
16s.
Now, Srija, show, yeah.
All right, Shiva, so you're using the full star sheath.
Yeah, full star sheath. I will show you the full star now. Can you show the sheath now?
Focus on the sheath.
Focus on the sheath. Hold it, Vijesh. So you can see that. See, that is a full star. It's basically St. Jude has got an edgeless sheath which is only 8.5 French, but full star is available in. Show this. Yeah, tip. So it just got a flexible sheath, and show here.
Shiva, we don't want to run out of time at the interesting part. So
Yeah. So now, right now,
try and keep moving.
I am advancing the full star.
And what French sheath is that?
This is a 10 French sheath.
Okay.
So now I am getting the full star into the intraatrial septum.
But Siva, you've used a 10 French because that means you can put any device you like in. Yes, all commercial plugs go through that device. The Occlutech, the AVPs, all of them.
I am planning to go for a muscular VSD device, a large muscular VSD device from the LifeTech, which is made up of PTFE rather than polyester, as the situation by an Amplatz or muscular VSD occluder, and so that is going to have a faster closure. So right now what I am doing is I am getting the full star across. I want Amplatz lift.
And any particular reason why you've selected a muscular VSD device, Shiva?
Because it's a fairly circular. Show the en-face view of the. You can now see the. You can now appreciate the size of the hole. It is more or less circular. It is not very oval. It is not very crescentic. So I feel that a circular device. Keep a 14 and 16 ready. So right now what I am doing is I am getting an Amplatz.
The measurement of that leak on 3D TOE, what was it?
Echocardiographically it was around 12 to 13 millimeters. 12 to 13.
Okay.
And we are planning to use a 14 or a 16.
Siva, I agree. It looks circular. The choice of muscular VSD, where
I want a straight wire. Straight.
A hemolysis risk versus an AVP2, an AVP2 device which would squash in there and stay away from the valve on either side.
AVP2 is now. AVP2 is another. Srija, can you go to LAO view? LAO. Yeah. Be there. That's enough.
Which catheter is that?
That is an Amplatz lift.
The wire across the leak, or
that's
right to the catheter?
So you're not using the full star in terms of steerability, are
no,
you?
right now I just want to try out with the Amplatz.
Okay.
Yeah, although it appears to be steering you away from the defect, the steerable sheath can probably really help you if you don't have as much smaller catheter exposed.
I think you are in pulmonary vein right now, right? How is the Echo Navigator helping you?
I am now using the.
Questions. So how is the Echo Navigator helping? How's the Star helping?
Can you see here the screen? The red dot here is the paravalvular leak. Can you see that here? I think.
Yeah.
Yeah. So that is the.
Yes, we can.
So that is the location, and so that on this projection I am looking okay. Come to RAO and tell me. Come to RAO, Srijar. See the location of my sheath in the echo, Srijar.
On the left upper.
So Siva, this is where 3D echo of that left atrium would be the easiest way to guide it, surely. I don't have echo now, but I've got Nilesh Sataria, so you can just show me the picture.
So the turn around and show. Take away that overlap.
We don't have Echo Navigator either, and 3D TOE is what we use for guiding us across. So
right now what I have tried out is the last 1 minute. So right now I am going to go retrograde from my arterial catheter, and as Dr. Allison was pointing out, I'll create a circuit. Get the same right coronary.
Shiva, we do have Echo Nav, and I would say 3D TOE is better in terms of looking at this defect. So if you can have your echo person guide you without the
exactly
Shiva,
without the bells and whistles of Echo Nav. I think also a multi instead of a catheter steering you away from the defect will help, and you'll cross at antegrade.
Shiva, we've got 5 minutes, I'm afraid, so I don't want to push you too much, but. You can talk, but keep doing things.
Yeah. So what I'm planning to do is now retrogradely.
I agree. I find that when you have the steerable catheter, you just need a multi or even just a wire at that point, and just use the steerable catheter.
Yeah, I mean, it's just a matter of several attempts, and the 3D echo will give the confirmation where the wire
Shiva,
is passing through. Yes.
Shiva, sorry about this. We're going to cut away from you, and once you're ready. Keep filming things. We'll come back to you, okay?
Yeah, sure. Go to LAO cranial.
Will that be all right?
Yeah, we are just going to cross now.
So we'll cut away and go for. We've got a bit of time to make up, so we'll go for lectures and then come back to you, Shiva, when you're ready with having crossed the lesion. Yeah.
Yeah. Now we have crossed. Yeah. So the wire has gone through the paravalvular leak. So now come back. Come back. Yeah. Come back to AP view. Come back to AP view. I want a little longer catheter.
All right, we'll stay with you now.
Yeah. So
you sounded like a snake then.
So right now my catheter is this is a little.
Your plan is to.
I will make a circuit and then go push the fooster. Yeah, planning to snare it in the left atrium. Right now, get a 6 French.
You do the circuit and snaring, and we'll.
Yeah.
Shiva, because I always worry about pushing and rushing people. So take your time. We'll come back to you after about 6 minutes.
Sure.
Okay.
Thank you.
So we'll go for a lecture.
So we get started with the lectures. Yeah. So I will invite Christoph Bartos to give the first lecture on the
get this
device for mitral cord replacement, result of FIM trial.
Shiva, it's John. If you can just give me a shout when you think you're at a point you're ready to deliver a device, then we'll come back to you.
We'll move straight away back to India, so we're connecting with Shiva.
Come to Arivo. Shaq, I will show you what
Shiva, can you hear us? We're live with you.
I'm able to hear you. Show back the next picture. Fluoroscopy. Next. Previous. Yeah, show here. So this is a catheter that we advanced. You can see that we are now crossing the paravalvular leak. The wire is now in the LA. Now next picture. So then we snared it. Next. So then when we tried to advance the foo star through the leak, the angulation was not supporting us. Next. So it was actually poking in, but it was not able to pass through the leak because of the direction in which our foo star was going, and the trajectory of the paravalvular leak was different. Next. So currently what we have done is next. Okay, currently what we have done is I have got another parallel wire into the left ventricle. I want an amplitude superstiff guide wire. So right now I have got a catheter that has gone through the paravalvular leak. So with the superstiff catheter, I will try to advance the foo star.
Listen, briefly.
Just very quickly, now that you have your rail, you can exchange for a shuttle that will go through that very easily.
Shuttle, and we were talking about AVP plug, is it?
Yeah, you can either snare the wire to give you...
Hang on, one at a time. So hold on, Shiva. Joe, go ahead.
Yeah, you can either snare the wire to give you more purchase on the circuit, but you've got also too big an elbow and the atrium. Yes, you're shortening it now. If you have it a little bit less curved, it will give you a better direction.
Okay. Yeah, so go on, Shiva. What were you going to say?
Yeah, so what I did was fluorostore this. So right now we have got... I have to hold the sheath. Hold the sheath, 1 second.
You don't need the rail anymore. You can put a body wire into the LV and take off the rail, which is driving you out into the LVOT.
Yeah. So right now I want to withdraw the guide wire, that is just a second.
So are you going to use a body wire method now, and or just go for a device?
No, Shaq, if you see through, I have got my catheter gone through the foo star. Can you appreciate it? The arterial catheter is now going through the foo star.
Oh right, yeah.
So
got you. Yeah.
So now I am trying to take out that arterial catheter. The arterial catheter has gone pretty deep inside.
Yeah. All right.
So Shiva. Now I am using the strength of the right coronary artery catheter.
Shiva?
Yep.
No.
The right
Can we come back to you in about 6 minutes?
Yeah, sure.
Okay, so you take your time. I don't want to rush you.
Oh,
it's a very important case. So you take your time. We'll join you in 6 minutes.
It's done, Shaq. It's over. Now can you see that the catheter has come out, and now.
Okay.
So I have got now the device ready. So as I planned earlier, I told you that we are going to have a 16 muscular VSD device. Open a LifeTech 16 muscular VSD device.
So at this stage, Shiva, whilst you're selecting the device, can they show you 3D transesophageal echo left atrial view
Srija,
with your sheath through?
Srija, left atrial en face view.
And at the same time, if you can carry on loading and showing the device
Yeah,
as
yeah,
well.
yeah. We'll do that.
Make the 3D TOE big for the time being.
So, TE bigger. Make the TE big. Yes, Srija, you go ahead. Get a en face nice view.
And a cursor and point out where the sheath is. Yeah.
It just
But
slipped.
we can't see it, Srija.
That is the sheath, sir. Just cross the paravalvulic.
Yeah, we see the valve very nicely now.
Okay. So, Shiva.
Sheet across.
Shiva.
Yep.
So I think we will come back to you because
Yeah,
your
sure.
sheath has come back, hasn't it?
Yeah, correct.
All
Correct.
right. So we'll come back to you in about 6 minutes.
Sure.
All right.
Shiva, it's John here in Frankfurt.
Yeah, John.
We're going to come back live to you.
Yeah.
All right. We're going back to Shiva for another connection. So Shiva, we're back live with you.
Yeah. So Srija is now showing the transesophageal echocardiography. I have got my sheath across through the left ventricle, but the sheath is getting stuck against some portion, and so I am trying to just get it released again. Can you run one ACT? We'll give another 2500 heparin.
On the 3D TOE, we see the sheath every now and then.
Yeah.
Yeah, I'm showing it.
Make it denser and then show.
Shiva, the device you're going to use is fitting into a 10 French, 9 French, or what?
It is compatible for a 10 French.
So can you leave a body wire inside, or you cannot?
Possibly, yes. I will try to leave. I have got my Amplad superstiff guide wire across, so I will try to leave this wire across. So
is the Amplatz 035 going to be too big for your body wire method?
Yeah, but let me try it out. What is the device that you are showing? 16. Yeah, okay. Show the device. Sera muscular VSD occluder. Open the device and show the paper. Get me a small loader. So the difference between the device is that this is a PTFE membrane, unlike Amplatzer, which is polyester. So now we are trying to load it on to the.
And there's a single membrane, or is there a series of membranes?
It's a three membranes. I want an ordinary, not this one. I want an ordinary. So I'm loading it in the normal manner.
And this is 16 once 1/6 millimeter diameter. Is that right?
Yeah, 1/6 with a 7 millimeter.
It requires what sheath normally?
It needs a 10 French, but now I'm having a buddy wire as well inside. Okay. And to check the compatibility, I am loading it on a 9 French. Yeah, I'm loading it on a 9 outside. The short sheath is 9. So now I'm going in.
Okay.
So right now I'm trying to advance.
Apparently it's going rather easily, isn't it?
Yeah.
Not a lot of friction, isn't it?
The trick will be where there's a slight kink in the food star, so it'll go through there.
Yeah. Well, it's going all right.
So right now I will try to withdraw the buddy wire or deploy it. Can you show me on fast the prosthetic valve? Come to RAO. Yeah. Come RAO. RAO further. Yeah. Yeah. Srija, how go on echo and show us.
Yeah, I'm showing.
Get a echo big there. Echo big. Yeah.
We deployed the.
Okay, looks nice.
So you deployed both discs, correct?
Yeah, I have deployed both the disc and I have taken out the buddy wire. Srija, how is the position?
Okay, and then quick view of the color.
3D on fast. Get a 3D on fast.
Color. Okay.
Yeah.
Color first and then 3D. Okay, that's looking good.
Can you show the 3D on fast now? The thing is whether both the discs are securely caught on all the angles. Yeah, go first 3Ds.
Yeah.
Rotate it.
So that's the left atrial.
I'm doing some wiggling. So the atrial side, tilt it nicely.
Yeah.
Tilt nicely the atrial side. Yeah. So atrial side seems to be well secure. Ventricular side. Yeah. Make the image gains lower. Further reduce the gains. Yeah. Now.
That's looking okay, isn't it?
Yeah, it looks fine to me.
We see some 3D color, maybe.
Yeah.
See some 3D color.
First, we'll get a 2D color.
Yep.
Get a 2D color.
Can you show us 3D color?
Yeah, we'll try for that also.
All right, 2D color then.
2D color first.
Yeah, it's at the top. There is a little bit of flow, but the top end is the pulmonary vein, isn't it, I think?
Well, it's difficult to say whether the leak is through the device or
usually this device.
There shouldn't be any leak through.
Yeah,
that's correct. You will expect immediate closure, yes?
Sorry, Shiva, what were you saying?
No, yeah, as you were pointing out, being a PTFE membrane, if it closes immediately. Srija, can you get some color on it?
You're flushing. I'm just color.
The left atrial pressure has come down enormously. Get the pressure up. Get the pressure scale bigger. LA pressure, which was we were getting some 60s, 70s, and all. It's a lot less now. Srija, just find out the security. The stability of the device.
One disc is on the LV side and the other disc is on the left atrial
Yeah,
side.
pull in, push out and see the, yeah, now we can keep pushing in. Yeah, now show the echo bigger.
So, Shiva, no rush, but we've got 1 minute.
Yeah, sure. Get the color on that area. Yeah, now keep adjusting the.
I'm going in posterior.
Yeah.
It's a very bulky device. It may cause leaflet erosion.
Pardon?
I'm afraid that it's a
This
very
is not
bulky
the-
device and it may cause leaflet erosion.
Actually, the leaflets are well inside the. Leaflets are away. The discs are completely outside the sewing ring and the casing of the device. You see, now this is the ventricular view. Make it denser, Srija. Show the leaflets
coming.
in the same ventricular view. Yeah, show the leaflets. You can appreciate the leaflets here. The device is actually lying outside.
Okay. So, Shiva, what are you going to do now? Because it looks, there's a little bit of leak, but otherwise it looks like a good result.
Yeah, hemodynamically okay. I am just looking at the stability of the device.
Cut.
That's okay.
So much of leak.
Now, can you just confirm that we are
just
fine?
1 minute, please.
Madhu.
This is needed, this angulation now?
Huh? You can take it now. Whether we go for some other type of device or we accept this residual flow, because the LA pressure has significantly come down.
What is the LA pressure now?
LA pressure is very low. Not 20, 10 and all.
Oh.
But that is with a side leak, so it may become different. The LA position seems
LA
good.
pressure looks okay. The other side, yeah, that is there. Yeah, so that's ventricular disc on the ventricular side.
But right now, what would you do? Release or?
I'd release.
Yeah.
I think hemodynamic is good. There may
Yeah.
be a chance of hemolysis. Let it go.
Yeah. So, Shiva,
Sure. Yeah, Shaq.
we're running out of time, so you've disappeared. Oh,
No, I'm here. I'm looking at the
what are you going
echo.
to do?
I'm looking at the stability of the device on the echocardiography.
Well, it looks quite stable.
It looks stable, yes.
Well, hemodynamically, the result is very, very good in spite of restricted shunt.
Yeah.
It's a hemolysis issue. Like
Yeah, sure.
There is a small.
Are you going to wait with the device attached for hemolysis to appear?
No, Shaq. I'm just checking at all the angles to just confirm that my device is well secure. What does Allison say? I heard Allison in the beginning.
Yeah. Alison, release or not release?
I would release.
That's it. Thank you. No more. Right. Alison would release.
Yeah.
Iqbal said he would release. Audience, show of hands. Those of you who think now, release.
Everybody in favor of
Okay, those who would not release. There are only 3 hands that say don't release. The rest of them say release. What are you going to do, Shiva? Go with the 3.
No, I will go with the majority.
No, disappeared again.
I will go with Allison's suggestion. So somebody asked for a color, so now I will get the color here. Yeah, try a color.
Yeah, we are out of time very quickly.
So I'm going to release it now. Srija, just get one 2D picture with a color again.
If anything, the leak is slightly less.
Lesser now compared.
I'm trying to talk him into this.
Just reduced now.
Huh?
Leak is lesser now compared to what?
Should I do a wiggle, Shaq?
Yeah, increase the. Pardon?
Should I do a wiggle?
Well, you can wiggle it if you like, but it looks pretty stable.
Yes, well, the device has changed shape a bit, and that may have helped with the leak, because the left ventricular disc was more bulky.
Yeah.
It looks better now.
Okay. So, Shiva.
Yeah.
Release before we get disconnected.
So released. Yeah. Now
okay,
see the
well
see
done.
the
That
location.
Is a brilliant case. And there's a little flame-like sort of residual flow and a little jet. Okay, so Shiva, we're going to disconnect and we'll see you later on. Thank you very much.
Yeah,
for
thank
the two
you.
cases, wonderful ones. Right, well done.